So the first bill we're going to hear, first of all, the Committee on Insurance and Banking will come to order. We'll hold off on roll call since we don't have a quorum. Senator Brown, proceed with Senate Bill 751.
Well, thank you, Madam Chair and members of the committee, member of the committee. For the record, I'm Senator Justin Brown, representing the 16th Senatorial District. I'm here today to present Senate Bill 751. Senate Bill 751 is legislation that attempts to prioritize patient care. This bill will rein a number of health insurance industry and big pharma practices that have had a negative impact on patient care and made a disadvantage to healthcare providers. Senate Bill 751 aims to prevent health insurance carriers and pharmacy benefit managers, or also known as PBMs, from discriminatory policies and procedures related to federal 340B program. The 340B program provides access to discounted pharmaceutical prices for eligible hospitals and federally qualified health centers who serve a large number of low-income patient and rural communities. This program is vitally important to the financial viability of many of our rural providers. Second, this legislation will prohibit the big pharma manufacturers from limiting hospitals, health centers from contracting with local pharmacies to provide access to 340B discounted drugs. This provision is new in this bill this year. I had this bill last year, and that provision was not in it. Third, Senate Bill 751 will limit the practice of white bagging. White bagging occurs when a health insurer or PBM will only cover a clinician-administrated drug if the drug is purchased from a specialty pharmacy outside of the hospital pharmacy. This practice creates many logistical and patient safety concerns that can lead to adverse outcome for patients. Finally, the bill requires insurers and PBMs to cover biosimilar drugs on the same basis as its FDA-approved biologic drug reference product. Biosimilars are comparable to generic drugs for brand name drugs. The opponents of this bill will try to make these issues sound complicated. They're really simple. This bill keeps resources in Missouri communities to protect access to health care for patients instead of shipping dollars out of state to pad the profits of big health insurance and big pharma. Thank you for the opportunity to present this bill. I'll try to answer any questions, and there are several witnesses here that will be able to explain a lot of these questions better than I. But I will tell you, I have 4 hospitals in my 7 counties, and I have one in particular in Dent County that's struggling really. I mean, they're literally week to week whether they're going to be open or not, and a lot of it has to do with these pharmacological things and the white bagging stuff. But if that hospital closes in the southern end of Dent County, Rolla would be the closest place to go. It's an hour and a half. So basically, unless you can get a helicopter down there, if you have an emergency that is life-threatening, you're dead. And that's what's happening. And the meetings that we've had with the insurance companies over this issue last year, I'm not sure whether they care or not, but this is why I'm filing this bill again, and I appreciate the opportunity to present it.
Thank you, Senator. Questions for the bill sponsor? Seeing none. Okay, I believe we have, Senator, did you say you need to leave, or do you, okay, you can go ahead and leave if you want to. What I'm going to do, or you can stay where you're at, whatever you want to do.
No, I'll be around. I'll be around here for questions.
Okay.
Does Angela have a question for me? You got a question?
I think she's good. All right. Okay, we have 3 seats down here. I want the first 3 people that are going to be in favor of this to come up and sit at the seats. We're going to start on this end and go down the row. As soon as your testimony is over, I want you to vacate the seat and go back to your seat, and the next person come forward. I think that will cut down on the time, letting people. Either that, or we're going to have to count your time from the time you leave your seat. So I think that'll make it quicker. So again, first 3 in favor, come forward. And remember, we just have about 2 minutes per person to testify based on the number of hands. Don't forget to fill out a witness form. If you'll need to fill out a witness form for each of the bills that you're going to hear. So this is just the first one to start with. So be sure and fill that out. Leave it on the table, and you may begin. Be sure and tell us who you are, and remember, 2 minutes.
Good afternoon, and thank you for the time to testify in support of Senate Bill 751. My name is Mariah Hollabaugh, and I'm the Director of Pharmacy for Citizens Memorial Hospital
and could
in
you
Bolivar.
make sure the green light's on and pull the mic up? Is the green light on there? Okay, I couldn't hear you very well. Okay, go ahead.
CMH is an 86-bed sole community hospital and health system that provides services to an 8-county service area northwest of Springfield. CMH, like many other hospitals across the state, relies on the 340B program to provide critical healthcare services to the communities we serve. This bill addresses predatory practices by insurers and drug manufacturers that reduce access to 340B medications, decrease payment to 340B pharmacies, and divert 340B savings outside of Missouri. The 340B program was designed to cover the gap between payment and the costs incurred to provide healthcare services. Because of 340B, we can offer a drug discount program and provide other critical services to our most vulnerable patients. When insurance companies or drug manufacturers siphon off those savings through contract restrictions or white bagging, it makes it even more difficult to care for our patients. These practices are creating patient safety concerns and barriers to access life-saving medications for our patients. The white bagging model is very confusing for patients and can delay care while we wait for a drug that may already be on our shelf. You may hear arguments that white bagging reduces costs, but we've seen several cases of increased waste. Temperature-sensitive medications have to be destroyed because these shipments bypass our normal ordering processes and arrive unannounced or unmarked at the wrong location. CMH has multiple patients that have experienced additional symptoms or relapse due to delays getting their treatments. Jody Gregg is one of our patients, and she's here today to tell you how her health was impacted by these practices and how 340B has allowed her to access life-changing medications.
Thank you for your testimony. Any questions for this witness? Seeing none, next up.
Hi, I'm Jody Gregg from Fairplay, Missouri. So I spoke with you all last year and about my Crohn's diagnosis and rheumatoid arthritis. It had greatly impacted my life and my family's. I was receiving treatment at MU, and my insurance dictated that I had to switch medications from a medication that was working for me. I was having no complications, and it was working great. I was forced to move to a biosimilar. At that time, I developed severe lung issues, was unable to breathe normally for 2 months, unable to really walk from a bed to a bathroom without almost passing out, blood pressure going up, all sorts of horrible things. At that point, we tried one more time, same thing, only worse. Then I had to move to steroids. Again,
I'm going to stop you for just a second. We're not going to count this against your time. We're going to establish a quorum since we have one. Madam Secretary, please call the roll.
Senators Crawford.
Here.
Trent. Brown. Hoskins. Huff. Mosley. Roberts.
We do have a quorum. You may proceed.
So I was switched to a different biologic, and again, the same thing happened, only I had even more complications from that. At that point, we had decided we weren't going to use biologics any further. I switched to steroids, which is a whole other host of things on your body to begin to deal with. At that point, I had decided that since insurance was dictating how I could live and not listening to my doctor or myself, my doctor's been my doctor for 30 years. He knows what I need, and they refuse. From 2022 to current right now, they're still denying medication that I need. I had made a pact to myself that I was going to get as healthy as I possibly could in case I needed additional surgeries. In that time of being off of the biologic, I did develop 3 new precancerous areas in my colon that I did have taken out. Since then, my doctor had prescribed a medication that insurance has denied and has continued to deny over the last year. The 340B program is a very crucial program. It brought me my life back. And I have, in this last year, I've lost 80 pounds. I can go up and down stairs. I can walk. I'm not missing work. I can play with my kids. I'm not in the bathroom 30 times a day by 1 o'clock. I can't tell you how wonderful that program has been to me in words. Every month, I have no worries. I know that the medication's going to be there. We do still pay a copay. It has given me my life, but we have also lost a lot. And in doing so, my husband has had to retire from his jobs. He's worked 2 jobs for 7 days a week. I worked 1 job 7 days a week. And we still couldn't afford, $88,000 treatments.
And I'm sorry. If you can wrap it up,
Okay.
please.
So, the 340B program, they are helping me a great deal. My husband did have to retire from his jobs and find another job that will pay more. But again, we're out, now we're out on life insurance policies, all these things that he's paid into, because when you retire, all those things go up. So we're taking that money that we would be paying for life insurance policies and continuing the same insurance or whatever.
Okay.
We're having to do.
Okay.
Yeah.
Thank you for your testimony. Nope, you're fine. I want you to say what you need to say. It's just challenging to get this all in, and you may go ahead and proceed. And if you'll go back, and then if somebody else will fill this slot.
Okay, my name is
Oh, 1 second. I forgot. Questions for the witness.
I'm sorry.
Trying to rush you off. Okay, I think we're good. Thank you. Go ahead.
Okay, thanks. My name is Jordan Cantola, and I'm the daughter of someone who is affected by this. So, as Missouri lawmakers discuss how white bagging affects patients, my sister and I would like to share our experience because we have seen the ugly side of this practice. White bagging not only affected our dad, Matt Cantola, it greatly impacted us too. Our dad was amazing. He was a snake guy from Grand Gulf State Park, and as a naturalist, he taught programs in many schools in southern Missouri. He loved his job, talking and embarrassing us as much as possible. He always...
Could you hit the button? Should be a green button on. Thank you.
Okay.
Pull that up a little closer. We're having a hard time
Got it.
hearing you.
Okay. So he always encouraged us to follow our dreams and preach laughing at the little things. He would not believe we would speak in front of so many people without being voluntold to do so. When our dad was first diagnosed with cancer in his rectum, he was excited because it was caught so early. It was caught by a let's check it off the list checkup. It should have been taken care of quickly and simply. However, there were issues from the start. As stated in the oncology case file cover, we would have already started treatment had this patient not been covered by BCBS, his insurance. Often, the oncologist will further adjust the dosage on a patient's performance status and/or lab work. If this order is dispensed by specialty pharmacy via white bagging, we will not be able to accommodate dosage adjustments the day of treatment, thus delaying patient care. When I called and told the patient the process, he was very upset. He made the statement that his insurance company was going to just let him die while he waited to get treatment. Unfortunately, our dad was right, and this was one of the many delays he had to fight against for the insurer and its designated company to deliver treatments.
And if you'll please wrap it up.
Okay, so eventually our dad struggled and died, and he had 90% chance of living had the insurance company not delayed treatment. So I ask all of you to change this healthcare providers so that all families get what they deserve treatment-wise.
Thank you. Questions for this witness? Seeing none, thank you for your testimony. Next up.
Thank you. Thank you to the committee for actually showing leadership on this growing problem of insurance accountability. And I want to thank Jody and Karen for sharing their stories of white bagging situations. This happens daily across Missouri, including Mercy, making it hard for us to uphold our mission to grant
Could you
access.
please introduce yourself? As
I'm
well?
Daniel Good.
Thank you.
I'm here to speak in favor of Senate Bill 751.
Thank you.
On behalf of Mercy, and I'm a practicing pharmacist in Springfield. It's important that we stand together on this problem. Large hospitals and small hospitals, urban, suburban, and rural hospitals. A couple of the other current bills that are very well written only address the rural healthcare FQHCs. It's imperative that the legislation cover all hospitals and treat all providers the same. This will allow all patients to have a choice as to who delivers their care. While Mercy has 3 large urban hospitals in this state, we also have 6 rural and 6 critical access hospitals that deliver quality care and provide great support that rely on 340B savings. Fortunately, within our Mercy network, we're able to help each other out and support each other through contracting, through shared medications during critical drug shortages, and sharing clinical expertise. Unfortunately, despite our healthcare system's size, we cannot negotiate price and reimbursement for these specialty medications distributed through insurance company, wholly owned, limited distribution specialty pharmacies. It is these pharmacies that dispense the white bags. My pharmacy friends in the insurance company try to convince me, and they'll try to convince you too, that the manufacturer sets a price. It's simply not the truth. The PBM sets a price of reimbursement as to that, in the case of white bagging, no reimbursement. PBM sets the price of the patient copay. Mercy, as a major provider of care in Missouri, has a large buying group that helps negotiate price for most medications, but the PBMs do not allow negotiations for these specially white bag medications. They practice a predatory pricing with threats of withholding other medical care agreements if we do not agree to their terms. On the flip side, as a provider, we are required to bill all patients the same, regardless of who the insurer is, whether it's a Medicaid or a state employee or another third-party commercial carrier. It is well documented that the same PBMs charge different patient prices for different patients and reimburse different pharmacies different reimbursement rates.
And if you'll wrap it up, please.
I will. This bill is going to help us ensure transparency of pricing and keep the cost of patients down. It will limit the PBM's ability to add bureaucratic roadblocks of unnecessary bureaucracy to add to our already busy and overregulated lives. Finally, let me add that it's imperative that we keep this business in Missouri. Almost all the specialty pharmacies that PBMs mandate are outside Missouri, and they're effectively mandating that we send our Missouri healthcare dollars to other states. I will stop here. Thank you for your time.
Thank you. Questions for this witness? Seeing none, next up.
Madam Chair, thank you for the opportunity. Craig Thompson with Golden Valley Memorial Healthcare in Clinton, Missouri. I want to talk specifically about the contract pharmacy aspect that would be solved with Senate Bill 751. So as a rural healthcare provider, Golden Valley Memorial Healthcare has clinics in Windsor, Warsaw, and in Osceola. And up until about 2 years ago, we were able to contract with retail pharmacies throughout our entire service area so that our patients could access those lower cost medications in their hometowns where they live. But because of these unilateral decisions by Big Pharma along the way, we've had to limit those contract pharmacy arrangements and those contract pharmacy agreements. So in many cases, we've got to kind of pick and choose who has the highest volume. And a lot of times it's some of the big box chains. So in our case, if you think about, we may have a contract with the Walmart pharmacy in Clinton, which means our patients in Warsaw don't have that same access to those lower cost medications. Getting from Warsaw to Clinton, there's no straight road in between, and a couple bridges you got to go through. So it's a real challenge for some of our patients to access those low-cost medications. In Windsor, Missouri, where we have a clinic, there's one pharmacy. It's a locally owned pharmacy, Merrifield Pharmacy. It's a father-daughter owned pharmacy, and we've not been able to contract with that pharmacy. So now we're steering patients away from that community and from that pharmacy, which means that pharmacy also doesn't receive the benefit of those prescriptions being filled there, which puts them at risk long-term as well. And I'll stop my comments there.
You have time if you need. You have 30 seconds.
There's a lot of people who have got a lot of great things to say.
Thank you. Thank you for keeping your comments succinct. Questions for the witness? Seeing none, thank you. Next up.
Good afternoon, Chairman Crawford and members of the committee. My name is Jonathan Barton, and I'm the Administrative Director of Pharmacy Services at Cox Health in Springfield, Missouri. I'm here today to testify in support of Senate Bill 751. The folks before me have done a pretty good job talking about 340B, so I really wanted to spend a few minutes talking about why these protections are so important for us and our community. One of the areas that I specifically want to highlight for you today is around the 340B program and how it facilitates patient access and why that access is so important for our community. One example of how 340B facilitates patient access is through our 340B specialty team. This is a very specialized team that consists of pharmacists, nurses, prior authorization specialists, and pharmacy technicians. This team functions as advocates for our patients, helping them get approved for the medications that they so desperately need via insurance, and then assisting with medication affordability as well as procurement. Our focus is on patients specifically with chronic health conditions who need that highly specialized and often expensive medication to help manage their disease state. Without these important medications, as you heard earlier, their quality of life would suffer. We also appreciate this bill in regards to the provisions around contract pharmacies as one of the many challenges. Our 340B covered entities contract with many pharmacies across our region to ensure that our patients have access they need to vital medications, especially given our service area is so rural, as you've heard earlier. With the manufacturer restrictions and being forced to reduce each 340B covered entity to choose a singular contract pharmacy, we, along with many other health systems, have felt significant impacts with these restrictions, which ultimately impacts patient access and ability to their medications. That's all I have. Thanks.
Thank you. Questions for this witness? Seeing none, Next up, and just a reminder to everybody to please fill out a witness form and leave those on the table, and you may proceed when you're ready.
Thank you. Good afternoon. My name is Karen White. I am the CEO of Missouri Highlands Healthcare. We are a rural, federally qualified health center serving 7 counties in southern Missouri. As I like to say, I'm just west of the Boot Hill. That's the very rural region in which I serve. We serve about 25,000 patients through our health center system, which consists of about 24 clinics. We have long been reliant on the 340B program for our patients to have access to the lower cost drugs. Specifically with the pharmaceutical restrictions or the manufacturer's restrictions on pharmaceuticals, we are having to pick and choose which pharmacies get which drugs. So for us, we don't have an in-house pharmacy. We rely on the mom and pops, which exist in each of the county or each of the communities which we serve in those 7 counties. We believe that that is the best way to do this. We don't want to be in competition with anyone. We want to support our communities. That's what community health does. And so we really rely on those pharmacies to deliver medications to our very sick patients. So right now I am having to pick and choose, which means that I will pick a pharmacy that has the most impact for my patient population, but it may be 2.5 hour drive from one patient needing that pharmaceutical to where we actually can deliver that drug. The folks in my area are not going to do that. They just don't have the resources. The roads are challenging to travel. The other very interesting thing that we do at RFQ is that we do a lot of Hep C. We have some of the highest cure rates in the state of Missouri at our silent on the distribution, which is why we were asking the state for help. Our ask of you is to ensure that the benefit of the 340B program goes to the covered entities as it is intended and not to the manufacturers or the insurance companies. Thank you.
Thank you. Questions for the witness? Seeing none, next up.
Hello, my name's Angie Littrell. I'm CEO of Fitzgibbon Hospital in Marshall, Missouri, and thank you for the opportunity to speak in support of this bill. I'll keep my comments not on the technical side, but mostly about access and the importance of a Soul Community rural not-for-profit hospital in mid-Missouri. We're an hour away from any tertiary care facility, and so care and access in mid-Missouri is critical. What the 340B program does for Fitzgibbon Hospital, it allows us to deliver babies. We delivered 275 last year. It allows us to provide a cancer program. It allows us to serve mental health patients in our inpatient mental health unit. All services that are provided reimbursement much less than cost. So without that, the 60,000 folks that we see in our clinics would have to go elsewhere. The 275 women would have to go elsewhere. And what that means when traveling is that people can die, essentially. So what the 340B program does is it provides funding for what it was intended, and we use it ethically and responsibly to fund those programs and support the services of the people we serve in our communities, the people you represent in rural Missouri. Therefore, it is critical. It's what helps me every night get up the next day and think I might be able to keep our hospital open. So it means millions of dollars to our hospital. It means care to the people in our communities, and the tactics to undermine what the program was intended to do simply are unacceptable. So I appreciate your consideration and support of the bill to support the patients that we care for. Thank you.
Thank you. Questions for the witness? Seeing none, thanks for testimony. Next up. And if you'll hold that microphone close, I'm having trouble hearing from that end for some reason.
Hi, and thank you for taking this opportunity for us to listen to us on behalf of the hospitals and FAQs here today. My name is Steve Davis. I'm the Chief Financial Officer at Sedalia, Missouri. Just like Ms. Luttrell said for Fitzgibbon, we're 35 minutes down the road. We also serve about 60,000 people. The biggest thing for us is we have an outpatient pharmacy at the hospital, but it is not licensed. It does not have a retail license. So in order for our patients to access this, with the regulations the way they are, our patients are going to be limited to most likely one of the big pharma places in Sedalia. Many of them live in rural communities like everybody else where they have local pharmacies that support that community, and the patients have the choice of whether or not they're going to drive that far. Most times, even in those communities, the number one reasons for cancellation is transportation. A lot of the people can't get there. So they're not going to go to a big city an hour away to get their meds. So what we like to do is have that to where all the patients have access to cheaper drugs for that patient themselves. And then also, in regards to white bagging, we approach this as not a financial thing for our hospital. It's more of a patient safety, because if the white bags, you don't know the delivery, how that was delivered. Was it in the back of a van at 100 degrees? Was it in a back of a van at negative 20? So that's the biggest thing for us. So thank you.
Questions for this witness? Seeing none, thank you for your testimony. Next up.
Yeah, Tom Greenlee, Senior Director of Pharmacy Services at University of Missouri Healthcare. I'm here on behalf of MU Healthcare to provide testimony in support of Senate Bill 751. My testimony today will be specific to the 340B program and its role in supporting safety net healthcare in Missouri. MU Healthcare is a state institution. It is one of 2 designated safety net hospitals in Missouri and also a 340B covered entity. A lot's being made about how large hospitals are using benefits from the 340B program. It's impossible to draw a straight line between MU Healthcare's 340B savings and any specific programs or services we provide. The reality is that 340B program, it really is a fundamental pillar of everything we do as a safety net healthcare provider. So I'd like to provide some recent examples of MU Healthcare's statewide impact, which are made possible in large part by savings from the 340B program. So providing $3+ million in annual prescription copay assistance to qualified low-income Missourians, adding services in communities like Boonville, Mexico, and Fulton, where rural hospitals have recently closed, staffing community emergency rooms at outside hospitals in Herman and Moberly, strategically placing helicopter services across the state to give quicker access to our Level 1 Trauma Center, providing physicians and nurses to serve outreach clinics across the state, investing in the children of Missouri by building a new children's hospital to keep care local for Central Missouri parents and their children, and integrating with Capital Region Medical Center at a significant expense to ensure the long-term stability of healthcare in the Jefferson City region. In the last year, however, MU Healthcare has seen a 17% decline in 340B benefit as a result of payer discriminatory practices and manufacturer contract pharmacy restrictions. This erosion of the 340B benefit, this erosion of the 340B program is increasing and is forcing us to make some difficult decisions around meeting the growing need for healthcare services in the state of Missouri. MU Healthcare is very different in our mission, and we're very different in our commitment to the state of Missouri. We're the last team standing in many of the communities we serve. The 340B program provides vital support for MU Healthcare's mission and vital support to safety net healthcare in Missouri, and it does it at no cost to the taxpayers.
And if you could wrap it up. Thank you.
I'll wrap up and just thank you all for your time today, and would appreciate your support for Senate Bill 751.
Thank you, too. Questions for this witness? Seeing none, next up.
Good afternoon. My name is Michael Calhoun, and I'm the Chief Executive Officer of Citizens Memorial Hospital in Bolivar, Missouri. We serve an 8-county area north of Springfield, about 130,000 residents in those 8 counties. I'm here to speak on behalf of Senate Bill 751 because it provides hospitals like CMH protections from discriminatory practices and attacks on the 340B drug pricing program. The 340B program is a lifeline to hospitals like CMH who are struggling to keep their doors open. On a routine basis, we read that local hospitals are either being closed or on the brink of closure. Several locally owned pharmacies in our communities have closed recently. This can be prevented if legislation can be passed to protect the 340B drug pricing program. At CMH, we provide health care to all patients without regard to their ability to pay their bill. 78% of the patients CMH serves are on the Medicare or Medicaid program or do not have health insurance at all. Over the past several years, there has been a widening gap between government payer reimbursements, which have been increasing at a rate of 2 to 3% per year, and the inflationary pressures on costs, which have been increasing conservatively at 6 to 8% per year. The 340B program is designed to support hospitals like CMH who rely heavily on government payers and serve as a healthcare safety net for their community. This program is under attack by pharmaceutical manufacturers and by insurance companies who are reducing access to these discounts in order to improve already healthy bottom lines. They're already in healthy bottom lines. The outlook for the financial viability of pharmaceutical manufacturers and insurance companies is bright. It's not uncommon to see profit margins of 20% or greater in these areas. Meanwhile, rural hospitals are struggling for viability. And at CMH, we have an operating margin of less than 1%. This makes us very vulnerable, making the health of our rural community very vulnerable. We need a representation to speak up on behalf of rural health care in Missouri by supporting Senate Bill 751 and taking the necessary actions to pass this legislation, and we thank you for your support.
Thank you. Questions for this witness? Seeing none. Next up in favor.
Hello, I'm Dorinda Dick. I'm the CEO of Western Missouri Medical Center in Warrensburg, Missouri. We serve about a 60,000 person primary service area and secondary service area. And really, everybody here, we've all said the same things. Rural hospitals, we are at risk for closing because of margin and pressures for reimbursement. But I wanted to put a few numbers to that. What I really talk about when I'm talking about rural health care is you are captive to the care that sometimes you need in an emergency in small communities. And so for me, I'm really passionate about making sure that we have the best stroke care, trauma care, because those minutes matter. And it costs money to run those kinds of programs. He was saying, we have a less than 1% margin last year. And for a small hospital, and negative margins the few years before that, for a small hospital like us, our only option for things like this, for pressures like this, would really be to affiliate with another hospital, a bigger system in Kansas City. And when you affiliate with bigger hospitals in Kansas City, generally what happens is they don't necessarily invest in your facility. And so you really do affect lives. You affect that ability to take care of those time critical type things and the specialty care that you need in these smaller communities. So 340B is worth about $6 million net to us a year. That is a significant amount of money for us when we provide about over $50 million of salaries to our community. So we really do pride ourselves on being responsible employer and the livelihood of many people in West Central Missouri. Thank you guys for listening.
Thank you. Questions for this witness? Seeing none. Thank you for your testimony. Next up.
Good afternoon, committee. Thank you for allowing me to speak. My name is Amy Weckman. I've been a practicing pharmacist for 25 years and currently pharmacist in charge of the outpatient oncology infusion pharmacy at Phelps Health. I'm testifying in support of Senate Bill 751. I specialize in cancer care. Cancer treatment has a high proportion of medications that payers require to be provided by white bagging process. This care model disrupts the quality of care for patients. Cancer patients are at a disproportionate risk of negative outcomes due to white bagging. The process presents many challenges to patients and providers. The most serious is delay of care, which is due to the introduction of an external process of sending an infusion or injection prescription from site of care to an outside pharmacy who do not compound the prescription, but instead bill the prescription benefit plan and secure the deductible and copay from the patient. They then send the drug back to the site of care for us to compound and prepare for administration, all while providing little to no coordination for when and where it will arrive, or providing us reimbursement to unpack, store, and compound the final product. This delay places undue stress and anxiety on Missourians while they sit and wait for treatment, not knowing when that day will come. Patients can be treated with the same drug and receive two completely different levels of care depending on the required use of white bagging. Due to many issues with the entire process, our oncology pharmacy does not accept white bagging medications for compounding because we cannot accept the risk to the quality of care we provide our patients. Unfortunately, cancer patients with white bagging mandates have to travel further for treatment from an already rural area of Missouri. Committee, we can't allow payers to dictate how and when our oncology patients will receive their treatments, especially when we have developed a proven system that provides safe, timely, and effective care with the buy and bill method. We owe our patients the comfort of knowing their treatment will be administered in timeframes recommended through proven research. The white begging care model shifts the cost and additional burden to hospitals, providers, and patients. Committee, please know that white begging is not safe, it's not timely, and not an effective process for our Missourians.
Thank you. Questions for the witness? Seeing none, just as a reminder, if anyone else is, thank you for your testimony. If anyone else is here to testify in favor of Senate Bill 751, please come forward at this time. Otherwise, I'm going to assume this is the last one.
Well, good afternoon, committee. My name is Dr. Casey Burton. I am the Director of Health Innovation and Policy, as well as a registered lobbyist with Phelps Health, a county hospital based out of Rolla, Missouri. And I thank the committee for its consideration of this bill. As a 340B hospital, the tangible impacts of the program to our patients and to our community are profound. As the committee well knows, rural hospitals like us operate in a challenging environment. The 340B savings realized by our hospital, which amounts to about $10 million per year, which is no trifling number for us, allows us to maintain access to high quality care for our patients. It allows us to maintain fair and competitive pay for our employees in a rapidly rising labor inflation that greatly outpaces the paltry increases offered by CMS. It allows us to maintain essential services such as our labor and delivery ward at a time when birthing centers across the state are struggling to stay open. In short, the 340B program and the savings that we accrue from it pass directly into our own local community as Congress originally intended. And they're not clawed back to out-of-state headquarters for for-profit institutions. In short, we strongly support the protections proposed in Senate Bill 751. I really hope that Missouri joins the ranks of other states like Iowa, Arkansas, Louisiana that have worked to rein in some of these discriminatory practices against 340B covered entities. And with that, I appreciate the committee's time and be happy to take any questions.
Questions for the witness? Seeing none, thank you for your testimony. Next up.
Madam Chairwoman, members of the committee, Organ Schlemer on behalf of the Missouri Pharmacy Association, also Missouri Primary Care Association. If you have some downtime someday and you want to go look at the 340B statute in the federal law, it's not actually that long. 340B is actually the section. There is nowhere in there that talks about, and there's no testimony or anything that we've seen in the congressional debate that says we've got a great idea. We want to implement these 340B rebates so insurance companies can capture them and make more money. They were always intended to go to covered entities, which are outlined in the federal law. This is a mechanism to ensure that the intended recipients get those discounts and they are not intercepted by the insurance companies. Thanks.
Questions for the witness? Seeing none, thanks for your testimony. Next up.
Thank you, Madam Chair. Members of the committee, Justin Alferman representing SSM Health. We would like to go on record in support of Senate Bill 751.
Questions for this witness? Seeing none, thank you for your testimony. Next up in favor.
Good afternoon, members of the committee. My name is Alex Tuttle. On behalf of University Health out of Kansas City, we want to be on record in support of Senate Bill 751.
Thank you. Questions for this witness? Seeing none, next up in favor.
Good afternoon, Heidi Lucas, Missouri Rural Health Association. We are going on record in support of this bill. Thank you.
Questions for this witness? Seeing none, next up in favor.
Madam Chair, members of the committee, Brent Hemphill here on behalf of BJC and Mosaic Life Care. I want to go on record in support of the bill.
Questions for this witness? Seeing none. Anyone else? Final call for in favor of Senate Bill 751. Seeing none. Anyone wishing to testify in opposition to Senate Bill 751, please come forward. Go ahead and come up. Use the 3 seats. We'll do the same as we did before. And don't forget to fill out a witness form, and you can proceed whenever whoever gets here in the hot seat, you can go first.
Thank you, Madam Chair. Members of the committee, Michael Henderson for the Missouri Insurance Coalition. In opposition to Senate Bill 751, Senator, I'm also here for informational purposes on 978 and 1035. I'm not sure if those bills are before the committee today or not as planned. First thing I want to point out is whether this bill passes or not, the 340B program is not going away. This is a federal program. Nothing we do here today. It's been rumored around this building that without this bill, the 340B program for Missouri covered entities will go away. That is simply not true. I also want to point out in response to the sponsor's remark that we don't care about rural hospitals. And the waning weeks of last session, my members were very involved in efforting a compromise on this issue. Would have included protections for federally qualified health centers, many rural health clinics and critical access hospitals, including Phelps County. It's my understanding from my members it probably would have protected the majority, if not all, of the entities that have testified before you today, with the exception of MU. We simply were not willing to do a compromise that would codify a guaranteed rate of return for the biggest hospital systems and the biggest abusers of this program. Make no mistake, in 2021, this program generated $44 billion under the program. That was a 15% increase from 2020. We are seeing abuses at the biggest levels by the biggest health systems. We are committed to finding a compromise to protect the smaller, vulnerable health clinics out there, but we simply will not codify any deal, that will codify for the larger systems their profit centers. It was MHA and their big hospitals, based on information and belief and what we were told during those negotiations, that refused to accept any compromise that would split its membership. Again, that's their choice, not ours. Simply, we have started to negotiate contract reimbursement rate on 340B drugs, separate and apart from drugs acquired from other programs. That's not new. Medicaid reimburses 340B drugs on an acquisition cost plus a dispensing fee. Medicare a little bit more, average sales price plus 6%. Simply, I also want to point out here, Mr. Schlemeyer pointed out 340B law says nothing about it rebating. It also says nothing about reimbursement rates. I have asked the opposition, hey, show me where you're guaranteed a rate of reimbursement on 340B drugs.
And if you could wrap it up.
Yep, absolutely. The last thing I will point out, actually, you know what, I'll just leave it there and allow those after me to go. Thank you.
Thank you. Questions for this witness? Seeing none. Next up in favor, we'll go with Shannon.
Madam Chair, if it'll please you, I'll save my comments on the 340B program for the other two bills. I assume we're still going to try and squeeze them in. So let's talk about the bill before us. Today I'm representing America's Health Insurance Plans and the Carpenters Regional Council. Strongly opposed to the two provisions in this bill regarding the regulation of PBMs as well as the white bagging issue. I sit before you representing companies that provide insurance coverage to millions of Missourians, people that aren't in this room today because they're out there working, trying to make sure they can put bread on their table, a roof over their head, and do the right thing, and that is provide health insurance either for their families through individual plans or employers who are doing the right thing and providing insurance to their employees. And we've heard a lot of discussion today, and in my little brain, I've got a lot of things bouncing around. I could talk about hospital consolidations, or I could talk about Medicaid expansion, because these arguments, we heard these 5 and 6 years ago, that the savior for the rural hospitals would only be if we could expand Medicaid. And many of my clients supported that and worked on that endeavor. But here we are today with that expansion in place, but the arguments are the same. And it's always the big bad insurers are the reason we can't make any money. And the fact of the matter is the big bad insurers are the best payers these individuals have. And it's been very clear by the testimony today that maybe the individuals behind me should be in Washington, D.C., lobbying to get better reimbursement rates from the federal government, because that appears to be where the problem is. It's not with us. At the end of the day, we're looking out for our members, and we want to make sure that they get the best quality health care at the best treatment center at the best price. And that's why issues like white bagging and PBM reform are so important to us, because when we see what these facilities charge and then we go out in the marketplace and see what we can save our members.
And if you could wrap it up.
That's where we go. And I'll save the rest of my comments for the other two bills.
Thank you. Any questions for this witness? Seeing none, thank you for your testimony. Next up in favor. All right, I'm sorry, in opposition.
Thank you, Chair Crawford. Sean Stevenson with the Pharmaceutical Care Management Association. We're the trade association for the PBMs throughout America. PBMs and their health plan.
I'm going to stop you for 1 second. If you two would like to clear the seats, we may have some others in opposition, and come on up, and we won't hold that 10 seconds against you.
That's fine.
Proceed.
PBMs and their health plan and employer clients use specialty pharmacies to deliver high-quality, accessible pharmacy services while promoting affordability. Flexibility to continue contracting with these select pharmacies is key to ensuring access and promoting affordability here in Missouri. When an employer or a health plan decides to contract with a PBM to administer their pharmacy benefit, they maintain authority over the terms and benefit plan design, including how drugs should be obtained or delivered to the beneficiaries. It's important to note that the employer or plan, not the PBM, makes decisions regarding cost-sharing requirements, formularies, networks, including the use of mail delivery of a drug to be by a patient or by a provider. While the vast majority of shipped prescriptions do not require special handling or packaging, for those that do, mail pharmacies, that is, use U.S. Pharmacopoeia guidelines to determine handling needs and leverage proprietary software to map out ideal packaging journey, which accounts for acceptable temperature range, forecasted weather conditions, and destination temperatures. Proprietary software is used by PBMs to map out a delivery path for those prescriptions that they must stay within a specific temperature range. Such software accounts for the acceptable temperature range for each prescription, forecasted weather condition, and destination temperatures. Specialty prescription drugs, including injectable drugs with the special handling requirements, are usually shipped through commercial mail and shipping carriers, such as UPS, Federal Express. Specialty drugs requiring refrigeration are typically shipped for overnight delivery, often through those common carriers. And for up to 60 hours is what the guidelines usually call for as well. Safety and efficacy of the mail prescription of the utmost importance are well reflected in the level of precision and planning undertaken by mail service pharmacies and the mailing of prescription drugs, including those with special handling requirements. The precision also reflects the needs and preferences of consumers, not only for sale, high-quality products, but also to know when the prescription will be shipped and be received.
And if you could wrap it up, please.
I can stop right there. Thank you.
Thank you.
Can I speak on the biosimilar real quick? The bill creates an open formulary for the biosimilars. We are opposed to that. This will only lead to increased costs because there will be no incentive for manufacturers to compete on drug prices at that point. Thank you.
Thank you. Questions for this witness? Seeing none, and this is anyone else here wishing to testify in opposition because you need to come forward? Anyone else in opposition other than these last two? Anyone for informational purposes only for 751? Okay, go ahead. Thank you.
Madam Chairman, members of the committee, I'm Chris Long, a registered lobbyist with the St. Louis Area Business Health Coalition. We're an organization of 50 major St. Louis area employers. We provide health benefits to over 500,000 Missourians. I'm going to be very brief. I have a lengthy letter that I'll submit to the committee. But in terms of these three pieces of legislation that are before us, and I know we're talking about Senate Bill 751 now, it's going to increase costs for insurance companies, but those insurance companies aren't going to eat those costs. They're going to pass it on to employers, which are our members. And employers, unfortunately, don't eat that cost. They pass them on to their employees in the form of higher copays and deductibles, or in the form of higher costs of goods and services, which is the end point. And we're already in a very inflated time period now. So we would urge the committee to defeat Senate Bill 751, and I will submit this letter.
Thank you for your testimony. Questions for this witness? Seeing none. Next up, final testimony in opposition.
Madam Chair, members of the committee, Randy Scheer representing Pharma. So we've been mentioned by both sides. The 340B program was initiated in 1992, and it was to become a safety net for entities to access affordable drugs to treat low-income and uninsured patients. The 751, and again, I'm only speaking to one small subsection, 376.14 subsection 3. That's the only one. The rest of the bill is fine. This bill would exacerbate the existing problems in the program by forcing manufacturers to ship 340 drugs and extend pricing to contract pharmacies which are not mentioned by the federal 340B statute and have become significant revenue generators for certain covered entities. And we've heard some of those admit that they were doing that. The bill's provisions directly conflict with the federal 340B program's rules and enforcement regime and restricts manufacturers' ability to impose reasonable conditions that are allowed under the federal law to make sure that those drugs and the pricing go to entities and are provided to the patients that were intended. We are committed to the program. 340B drugs and the pricing is a program that the pharmaceutical manufacturers provide. We provide the money as well as the drugs. And right now, I might note that there similar provisions to this have been passed in a couple other states, and it's currently being litigated in federal court. So that would be something to consider. I'll stop there. I appreciate your consideration. And again, our only concern is with that one small subsection.
Thank you for your testimony. Questions for this witness?
And we have no position on the other two bills.
Thank you. Seeing no questions, thank you for your testimony. One final call for those in opposition to Senate Bill 751. Seeing none, anyone here for informational purposes only? Seeing none, this will conclude the hearing on Senate Bill 751. Next up, we're going to do Senate Bill 978 and Senate Bill 1035 together, since they are the same bill. One more time, let me see a show of hands for those here wishing to testify in favor of those bills. In opposition? Okay, so we'll start with the senators. And Senator Trent, do you want to go first? Or I don't know how you guys, did you guys talk at all? It doesn't matter to me which one goes first.
We do talk. Let seniority go first.
Good afternoon, Madam Chair, and thank you for listening to Senate Bill 1035. It's on. It's on.
That mic's not very hot. Pull it up close.
Closer to it. All right. Okay. Thank you for hearing these bills today. I'm going to be real quick because I think you've heard a lot of our bills are just basically a scaled down version of what you currently heard, and I feel like there'll probably be nobody against these bills, and these will sail right through, and we can maybe even exec them today. So this would simply just affect the FQHCs, and it would allow them to be able to get the same benefits that are currently given out through the 340B program, and allow those prices to be, there'd be no additional fees and other things like that. And I can go into it more. There's experts here that'll probably talk about this. I don't know if the senator cares to weigh in.
Thank you, Madam Chairman, members of the committee. Curtis Trent, District 20. I also won't belabor this since we just heard an extensive testimony about this issue. This is for the FQHCs, and essentially would like to see, this bill or something approximating it as a compromise go through that maybe sidestep some of the broader, thornier issues of the prior bill. So that'd be happy answering questions.
Thank you. Questions for the bill sponsors? Seeing none, if you two gentlemen wouldn't mind to step aside, we'll go ahead. I don't think we're going to have the trouble with, we've just got about 5 minutes though, so if you'll keep your comments short. Those here wishing to testify in favor of Senate Bill 978 and or 1035, be sure and notate on your witness form how you want to testify. If it's on both, I would assume it would be, since they're the same. And you may proceed.
Thank you. I'm Ryan Kruger, Jordan Valley, large federally qualified health center down in Springfield. We have 65,000 plus unique members, and I really wanted to just talk about a story in support of all three. The 340B program was made in 1992 that enables covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients. I want to share a story where we just had in our clinic. We had an uninsured patient show up with COPD. She gets diagnosed and she gets prescribed an inhaler, and this is a specific contract pharmacy problem. The only contract pharmacy that is eligible to provide her this medication at a low cost is our Lebanon Jordan Valley pharmacy, 60 miles away. So we had to enlist administrative help and our pharmacy in Lebanon to be able to get that medication for this patient. But more importantly, that patient didn't have the means or the ability to travel 120 miles round trip. So Jordan Valley more than happily put together a process to get a courier to get that medication while this patient sat in our lobby and really struggled to breathe. And it took us about 3.5 hours to get this whole process taken care of, where she could have went to the Walgreens downstairs in our clinic and gotten the medication probably within the hour. We did take care of this patient. She was very thankful in that situation, but I want to just correlate this back that this does not allow the FQHCs to provide equitable access to medication, nor stretch our federal resources to provide more patient care. Putting together a plan, traveling 120 miles round trip with a courier and multiple people to get one medication for one patient is just an example of why we support this bill.
Thank you. Questions for this witness? Seeing none, thank you for your testimony. Please be sure and fill out a witness form and leave it on the table. Next up, in favor of Senate Bill 978 or 1035. Seeing none, anyone here wishing to testify in opposition to Senate Bill 978 and or 1035, please come forward. If there are more than two of you, if somebody wants to fill in the third seat, that'd be great. We'll get them all done.
Madam Chair, members of the committee, Rob Monsess on behalf of the Missouri Hospital Association here to testify against the two FQHC only bills. As was referenced earlier, that MHA was opposed to the carve-outs, carve-ins from last session. That is correct. We think if this behavior is so wrong that it deserves correction by state policy, it's akin to stealing. These people are essentially train robbers. The reason they're okay with the FQHCs and the rural hospitals is because there's not as much money at stake there. They will never agree to the same protections being in place for the bigger hospitals. There are all kinds of claims of abuse. We've seen no credible evidence of abuse in the state of Missouri. So if it is bad behavior in a rural setting, it should be bad behavior across the board. But that'll conclude my testimony.
Questions for this witness? Seeing none, thank you. Next up, in opposition.
Again, Sean Stevenson with PCMA. Practice of notifying PBMs when a drug was obtained via the 340B program is one that is required in government programs such as Medicaid, including Missouri Medicaid. Medicaid programs generally require claim modifiers on 340B claims, which identify those as 340B claims and prevent duplicate discounts. Providing the claim modifier will ensure rebates are credited to the appropriate plan and help 340B practices align with congressional intent. So while I'm here in opposition, if the lines 78 or lines 78 through 80 on page 3 were struck, we would be neutral to the bill. Be happy to take any questions.
Questions for this witness? Seeing none, thank you for your testimony. One final time, anyone here wish to testify in opposition to Senate Bill 978 and or 1035? Anyone here for informational purposes for 978 or 1035, please come forward. We have 3 seats up here, so I see 2 people coming. Anyone else here going to do informational purposes only? Okay. Either one can go first.
Madam Chair, Shannon Cooper today, representing America's health insurance plans, and I will take the prestige of being the individual representing the train robbers. I provided to your able assistant earlier today, I believe 5 articles which will directly go in opposition of the comments that were made earlier about health insurers and the 340B program. And let me be clear, the 340B program is a good program. It was started with the greatest of intentions, and as health insurers, the less uncompensated care that our friends in the provider community have to give out, that is a direct reflection on what our rates will be. So we are not opposed to the 340B program. What we are opposed to are individuals who have taken advantage of this, not for the individuals who this program was started for, but for their own bottom line. And I will reach out and say that the majority of the people behind me today that rely on the 340B program, those are the individuals who this program was created for. I have the greatest faith that they are doing the right thing. And as we have spoken about this compromise that is out there, there is a pathway to put this issue behind us. And that pathway will protect the individuals who are doing the program right, but it will not protect those who are taking advantage of it. And I know I'm short on time, but I will encourage all of you to read those articles. They lay it out very clearly. Those articles are from states across this country as well as Washington, D.C., where their hearings took place last December because the federal government even recognized how bad some individuals are misusing this program. With that, Madam Chair, I'd be happy to answer any questions.
Thank you. Questions for this witness? Seeing none. And finally,
thank you, Madam Chair, members of the committee. Michael Henderson from the Missouri Insurance Coalition. Just want to go back to a point Mr. Monses made. I think it's important to realize that it could be MU, it could be another large hospital system. Once they're a 340B covered entity, they can acquire those 340B drugs and distribute them to any patient under their care. It doesn't have to be the indigent, those that aren't being served. So these really are large profit centers for those bigger hospitals. Absolutely, we treat covered entities differently. The federal government does. If you look at the bill that's been filed, we look at 256B, and you've got the subsets. I mean, there's subsections A through O defining separate healthcare entities. Absolutely, they are different. We go back and we're constantly hearing from our opposition, there's been no abuse. There's 55,000 covered entities. HRSA is able to do about 200 audits a year. When they do audit a larger hospital system and say you're misusing these funds, we know from cases like the Genesis case coming out of South Carolina that the hospitals will fight tooth and nail to then say, actually, you don't have authority over us to enforce this program. So they're trying to have it both ways here. Happy to answer any questions.
Questions for this witness? Seeing none, thank you for your testimony. Final call, anyone else for informational purposes only? Do either one of you senators want to make any final comments? This will conclude the hearing on, I just flipped my Senate Bills 978 and 1035. This will also conclude the hearing. Thank you for your patience. Thank you for talking fast. If any of you don't feel like you got your enough time, please contact my office and we will disperse your information to the other members of the committee. And with that, we are adjourned.